So what we're going to talk about today is informed medical decision making. And the reason why informed medical decision making is important, actually a couple of reasons. First of all, because most people are not making informed decisions. And the second thing is because if we use informed medical decision making as a way to approach people about health issues, it leads to the decision to make diet and lifestyle changes. How many of you have approached somebody and said, I'd like to talk to you about your diet, or you're getting sicker? Have you ever thought about diet being used as an intervention tool, and they're not interested? Anybody had that experience? Okay. Well, I want to make you, first of all, know that it's not you, it's them. I was unable to convince my own mother that she should change her diet. She died 4 years ago, and she died of what I think are foodborne illnesses. Then she was over-medicated, over-treated, too many procedures, would not listen to what I had to say. So you've probably heard this before. It's hard to be a prophet in your own land. I can't be a prophet in my own land sometimes either. I have to fly to Orlando, Florida, and find people to talk to, all right? Because some of the people in Columbus don't want to listen to me. But the point is that many times if we talk to people about healthcare in a broader picture, and we let them see how ineffective some healthcare is, they become surprisingly interested in changing their diet and lifestyle habits. And so we're going to talk about how to achieve better health outcomes with informed medical decision making, and how approaching people in this way can actually lead them to maybe be more receptive about listening to you about other things. Okay, so this is our mission statement at Wellness Farm Health. We believe it's a fundamental right of all consumers to have a complete analysis of the risks and benefits of any test, drug, supplement, procedure, or medical practice of any type before making a decision to proceed. How many of you agree with that? Okay, now having said, everybody raises their hand, how many of you regularly, before you made this conversion to a healthy diet, or even now, have conversations with your doctor that go something like this? Your doctor says, I'm a little bit concerned about some of your biomarkers. Now we have a couple of choices. I could medicate you, and that would solve the problem really quickly, but I want to really make sure you understand the risks associated with these medications, and I'm going to give you some information to read. Take it home, review it with your family, and come back next Wednesday and tell me what your decision is. How many of you have those kinds of discussions? One person in the room, right? Most people, what happens is a doctor says, take this drug. The patient says, okay. You find out later on that maybe that wasn't such a good idea. So we have to do this differently. You know, the worst thing I hear in my office every day is, if I had known then what I know now, I never would have, and you can fill in the blank, whatever that decision would have been. All right, so medicine today, and I think all of you would agree, if we take a look at what's going on in healthcare, it's expensive, it's impersonal, it's not very collaborative, it's not evidence-based. I'll prove that to you by the time we're finished here. A lot of diagnostic tests, drugs, and surgeries, the benefits are exaggerated, the risks aren't talked about enough. Consumers are unhappy. I have news for you, health professionals hate it too. My colleagues who work in hospitals and medical institutions wish that they were architects and plumbers and roofers and something else, anything but what they're doing now. And there's no question that the system is ripe for upheaval. It really does have to change when things get to this place where everybody's unhappy. The bad news is everybody's unhappy. The good news is it really is ripe for change. So what is informed medical decision making? Let's make sure we're clear on what the end point is here. The patient's given objective information about health conditions and what causes them, develops a clear understanding of the risks and benefits of any option that's put forth, has the freedom to choose the best option based on the patient's value system, not the doctor's. And what basically we're trying to do is change the concept of informed consent. So what informed consent means right now is the doctor says, do this, we call that informing, and the patient says, okay, and we call that consenting, all right? The better way to do this would be for a doctor to put forth a group of a repertoire of choices, along with risks and benefits, and then the patient really has options to choose from and informs the doctor of what the decision is and how things are going to go from here. Now, some people disagree with many things I have to say. Some people have even called me controversial, okay? And my answer to that is, I'm wondering when telling the truth became controversial. It seems to have become a very controversial thing. But with that in mind, and also keeping in mind that the objective is informed decision making, taking control of your health isn't doing what I say instead of what somebody else told you. All right, and that's so often what happens. People give their lives and their health over to other people to make decisions for them. Taking control of your health is doing what you want to do based on your understanding of the options. So if you disagree with something that I say here today, that's fine, because it's the decisions that you make about your body are very personal to you, and I don't really have a horse in the race. So this is not about doing what I say. So the best way to illustrate this point, let's have an informed discussion about coronary artery disease. And the reason I picked coronary artery disease is we're still at a place where over 40% of people in the United States die of heart disease, something related to heart disease. So it's the number one killer in our country and in many westernized countries as well. So since it affects so many people, let's see what that looks like. Now, the first thing we'll do is we'll review traditional options for treating coronary artery disease. One of them is, a marker for coronary artery disease, is statin drugs, Lipitor, Crestor, you've seen the ads. If you look at the efficacy rate for these drugs, Crestor reduces the risk of having a major event by 1.2%. That shocks most people. Lipitor is the best of the bunch at 1.6%, and if you average out all of them, it's really 0.7% drop in the risk of having a major coronary event. Statins don't reduce mortality when used for primary prevention, and less than 50% of patients continue to take them because they have side effects. Now, I've been asked for years how I get people to want to change their diet and lifestyle habits. Well, when you start putting this kind of information in front of people, it disturbs them. Because unfortunately, one of the bad things that happens in medicine is we lull people into a false sense of security, thinking that the drugs that they're taking, the procedures they're agreeing to, are actually providing them with better health, when actually that's not the case in many instances. Now, let's look at just a couple of side effects of statin drugs. Now, just to be clear here, I'm summarizing a lot of things. I have a 3-hour lecture just on statin drugs, but if we got to do the whole extended version of everything I'm going to say here today, I would be long past my time, and I am watching this. It's a very interesting thing here. They tell you exactly when you have to finish, this little clock here. All right, so let's look at one thing. Statin drugs do cause cognitive decline. In fact, the FDA moved cognitive decline to the top of the list a few years ago. And in a double-blind, placebo-controlled study involving a number of adults taking statin drugs, the conclusion was 100% of statin drug users will experience some cognitive decline. Okay, that's a pretty serious side effect. Musculoskeletal injuries, and I'm not going to read you all the stats on these slides, I'll just tell you the summary here. One person is harmed for every 37 to 58 people who take the drugs. And one of the number one reasons why people stop taking them is almost instantaneous onset of musculoskeletal pain after they start taking the drugs. Some other risks: increased risk of moderate or severe liver dysfunction, acute renal failure, myopathy, cataracts, esophageal cancer. For women, the number of women needed to treat to prevent one case of cardiovascular disease over 5 years, 37. For men, it's 33. Lots of people have to take these drugs with all those side effects just to prevent one episode of cardiovascular disease. Now, this is very interesting. The average person who takes statin drugs increases their fat intake by a significant amount and their calorie intake. And the people taking statin drugs have bigger increases in their BMI. And a lot is being written about this in medical journals today, which is that the false sense of security that comes along with taking drugs that have such limited efficacy, one of the major side effects is thinking everything's taken care of. I can eat steak, I can eat French fries, I can have fried chicken, because my cholesterol is low because I'm taking a statin drug. So perhaps the worst side effect of these drugs is the false sense of security associated with taking them. It causes people to misbehave even more than they would have otherwise. Now, here's another drug that's commonly prescribed to people who have markers for cardiovascular disease or are at risk, or increasingly, not at any risk at all. Have you ever noticed that lately you reach a certain age and you're supposed to start taking certain drugs because you've reached that age? Aspirin's one of them. And there are great big campaigns on television telling people to ask their doctor about starting an aspirin regimen because you're 50, or because your brother had a heart attack, or something of that nature. Actually, aspirin is pretty useless, particularly for primary prevention. And if you look at the data, For every event you stop, you have an equal number of events that involve bleeding out. Okay, so again, I think most people buying an over-the-counter, inexpensive aspirin think that they're protecting themselves a whole lot more than they are. And the fact that it's over-the-counter makes people think it's less risky than prescription drugs. That's one of the problems with over-the-counter drugs, is just the perception that they must inherently be safe. Treating hypertension. A lot of people who die of cardiovascular disease start with markers like hypertension. There's such a thing as a J-curve, which tells you basically what this means, and putting it in simple terms, is that sometimes the more treatment you deliver to somebody, the worse you make them. So the more drugs you give them, the more you lower their blood pressure, the worse they actually get. And then this is a paragraph that actually came out of the minutes of the European Hypertension Society's meeting in 2014, where a doctor got up there and then said, we have this other problem, and that is that we don't even know what ideal blood pressure is and the target for treating. Now, doesn't that fill you with reassurance that a bunch of expert cardiologists meeting in Europe to discuss how to treat patients are basically saying, we don't have a clue, all right? Now, reducing blood pressure to below 140/90 is associated with more heart attacks, strokes, and deaths. And the Cochrane collaboration, the most independent medical research organization on the planet, says that when you lower blood pressure below 140/90, you really don't reduce deaths, you may increase the death rate. People over the age of 60, these are studies here showing people over the age of 60 shouldn't be medicated until their blood pressure reaches 150/90. Other studies show 160/100. The point here is not that we should leave people with high blood pressure alone. The point is that we're over-medicating people. And these people would be excellent candidates to change their diet and lifestyle habits in order to reduce their risk of having a heart attack. Now, this little chart is hard to see, but what it basically shows is this, and this is something to remember both for yourself, your family members, and other people you care about. The smaller the abnormality, the less likely you are to benefit from treating it with drugs, okay? So if you have ridiculously high blood pressure, I still think it's a better idea to lose weight and eat better. But you may benefit for a while from taking an antihypertensive drug. But if your blood pressure is just a little bit high, more harm than good most of the time. And so one of the numbers we use to evaluate this all the time is called the number needed to treat. And so what you'll see is that the number, if you look at the risk reduction, if your diastolic blood pressure is really, really high, you're going to get an 80% reduction in risk. That's significant. If it's not very high at all, you're going to get a 9% reduction in risk. And so when you get down to those smaller numbers, because your abnormalities are smaller, you have to sometimes treat hundreds and hundreds and hundreds of people for one person to benefit. And you know what happens to the hundreds of people who aren't that one person? No benefit, all side effects. Those are people who should be taught to change their diet and lifestyle habits. In this particular study, looked at 26,875 people over the age of 45 who had hypertension, and they looked at people who had normal blood pressure, pre-hypertension, stage 1, stage 2, 4 classes of medication used. And the bottom line is 4 classes of medication, meaning how many drugs you took. 46% of the people who were successfully treated, I put air quotes around that, successfully treated, had strokes. Now, in what universe do we consider 40% of successful treatment involves stroke? In the medical universe, that's where we think that. Even worse, the stroke risk increased for each additional drug added. So the more they treated these people, the more heart attacks and strokes they had. All right? Now, how many people think that if a lot of folks saw this kind of information, they'd say, sign me up for diet change? Okay, we're not finished yet, right? There's more. This is the most recent trial, and I'm not here to bash medicine, but I am here to talk to you about how misled people are by what the newspapers report, by the perceptions in medicine, by people who are in authority and have a great deal of prestige associated with their name. This SPRINT trial, let me tell you what happened here. This trial was designed to see what would happen if you started medicating the heck out of people, really ratcheting down their blood pressure to what are considered ideal levels by adding drug after drug after drug after drug until you reach that target number. And I think it was 2014 or 15, at the end of last year, They stopped the trial early because the benefits of medicating people this way were so spectacular that it was considered unethical to withhold the additional drugs from the control group. Okay? Now, at the time, they released no data at that time, and if you go back and check my archives, I actually wrote an article at that time saying, wait until the information comes out, because when we really get a chance to look at the data, we're going to find out that it's not quite as beautiful as they say that it is. Nonetheless, this doctor writes that this is the most important blood pressure trial in the history of cardiology. It's going to be a game changer. Okay, now here's what it basically said. The incidence of events dropped from 6.8% to 5.2% over a 3.2 year period of time. We're talking about a reduction of 1.6%. Okay? 1.6% reduction. Now, look at this. For every 1,000 people treated during that period of time, 16 people would benefit. We'd hurt 22. Okay? In what universe does benefiting 16 and hurting 22 to get there considered a good outcome? And then they said, well, for the rest of them, it was just a wash. Okay, well, some of these people were taking 4 drugs. How can they say that the rest of these people were not harmed in some way? Maybe not during that 3.2 year period of time, but certainly taking 4 blood pressure drugs sooner or later, if you look at the side effects from these drugs, would catch up with you. This is considered big advances in cardiology. This is the best it gets, all right? Angioplasty involves risk. In fact, sometimes the procedure causes the event it's trying to prevent because the balloon nicks one of those plaques and all the toxic ingredients spill into the bloodstream. You end up with a clot. In fact, about 15 to 20,000 times a year, people have a heart attack right on the table, and 10,000 of them die. Now, frankly, most people don't die. We do about 500,000 angioplasties in this country every year. But what happens to the people who don't die is that 50% of their arteries clog back up in 6 months. 6 months. All right, why is that? Because people leave the hospital and go home, and before they leave the hospital, their first meal is meatloaf and sausage gravy delivered by the cafeteria, and then they go home and they continue to eat the way that they did before. Now, this study was amazing, and there are several like it in the medical literature. The AVERT study showed that people who just took Lipitor, the study was designed to see what happens if you give this group Lipitor and this group angioplasty. The people who just took Lipitor had a much lower risk of heart attack, readmission to the hospital, and death. Now, remember the efficacy rate for Lipitor? 1.6%. We actually in medicine have designed a procedure that costs tens of thousands of dollars that is less effective than a drug that has a 1.6% efficacy rate. This is hard to do, folks. This takes incredible American ingenuity to come up with this stuff. Bypass surgery? Here's the problem with bypass surgery. It bypasses the arteries close to the heart only that usually have calcified plaques that are unlikely to rupture. But the bigger problem is that with cardiovascular disease, coronary artery disease, if you have it in one place in the body, you've got it everywhere, all right? We do not have a roto-rooter system that goes through the body and routes out all of the garbage that lines your arteries, like the roto-rooter system that will come clean out the pipes in your house. So you really don't fix the problem, and in fact, 3 major studies have shown that bypass patients after the surgery really are not better off than people who just take drugs. Now, there are applications for all of these things, and I want to make this perfectly clear before we go to the next thing. We should do bypass surgery, probably 15,000 times a year, not 500,000. We should do angioplasty, probably 15,000 times a year, not 500,000. Some people should take statin drugs if they have familial hypercholesterolemia. But you see, the problem is if you just did these things or gave these things to people who qualified, you can't make billions of dollars. The money is in doing it for everybody. All right, so now let's look at, part of our informed discussion is if somebody says, well, you know, I was all geeked up about having bypass surgery because frankly, laying on a hospital table, having my chest ripped open and all that, it sounded like so much fun. But now you've talked me out of it. So I'm going to be open-minded and look at what else you might recommend. So let's look at an option. And I'll introduce an informed doctor, Caldwell Esselstyn. If you saw Forks Over Knives, he was one of the featured doctors. I think it's interesting that so many people who are involved in doing the kind of work that I do and Dr. Esselstyn does, we all started our lives as pretty traditional healthcare practitioners. And Dr. Esselstyn did. He was head of the breast cancer surgery unit at Cleveland Clinic for a very long time. And he got interested, like a lot of us, in looking at health outcomes in other places, discovered that in many places in the world, people don't have so much cardiovascular disease and not so many people die of it. So anyway, when he decided to go a different direction, he did a study. He enrolled 24 patients who had had 49 events. These were some pretty sick people. 5 of these people were told back in 1985 when this started that they would not finish out the year. They'd been sent home to die by their expert cardiologists. And so he put them on a diet, much like the one we'll talk about shortly here. And after dietary intervention, using a plant-based diet, their cholesterol dropped by about 100 points. For many of them, disease progression stopped. For some, it reversed. And I don't know how many of you have seen his book, but he has angiograms before and after showing that these diseased arteries repaired themselves. Now, we don't have any surgeries or drugs in medicine that create that same result. Chest pain was reduced or disappeared, exercise capacity restored, sexual function restored. The most important thing, perhaps, is none of these people ever had any more procedures, events, drugs. They remained stable. And the 5 who were supposed to be dead in 1985 are still alive today. 2 of them were in the movie Forks Over Knives with me. Now think about, do you think that this type of discussion is going on at any pharmaceutical convention in Florida right now? Talking about this new drug that we have that creates these miraculous results where people outlive their diagnosis by 30 years routinely? Not so much. 6 patients left the study. They thought it was too hard. That's usually what people say, this is so hard. And I always wonder, well, I guess what is your definition of hard? It's pretty subjective, actually. But 6 patients left the study. They had 4 cases of chest pain, 2 cases of ventricular tachycardia, 4 bypass surgeries, angioplasty, congestive heart failure, and death. When we get to this issue of so hard, how many people think that angioplasty or bypass surgery or death are hard? Okay. I really think eating some black bean chili and going out to run is much easier than bypass surgery. I'm just saying. Everybody makes up their own mind on this, but look at the difference here. 13 events and 6 people who decided not to stick with it, none in the ones who did. Dr. Esselstyn has continued doing this type of work. This is a study that he published a couple years ago on the 198 patients who followed the original 24. Notice the 90% compliance rate, so much for how hard it is. 0.6% incidence rate in the compliant group, 62% in the non-compliant group. I mean, it really speaks volumes. So think about this from the perspective of somebody looking at this for the first time, if the informed discussion was actually going on. We go through cholesterol-lowering drugs, aspirin, hypertension drugs, angioplasty, bypass, and all we're doing, this isn't my opinion, this is what the medical literature says. And that's another thing too, if we get this out of everybody's opinion and we just stick with the science, the story unfolds and tells itself just beautifully. We don't have anything to argue about anymore. We're just looking at science. And then this is the option. How many people think that some folks might be motivated to do the diet change if they saw this? That's the whole point. And since this discussion is not going on in doctors' offices, we just have to take it out to venues like this. Now let's look at a couple of different outcomes for people. Let's start with an uninformed consumer. And the interesting thing about this particular individual is he was informed about just about everything else. Tim Russert was a well-known and much beloved newsman who I missed during this election cycle like you can't believe. I would have loved to have heard what he had to say about these things, right? Well, anyway, he was a wealthy man. He had excellent insurance coverage, and he went to the best doctors in New York, and I would put air quotes around that. And he took all the right drugs for his conditions. He was taking a statin drug, a hypertension drug, a prediabetes drug, and a daily aspirin. His biomarkers were excellent. In fact, he saw a physician in New York City who signed off, sent him home with a clean bill of health just a few weeks before the heart attack that killed him at the age of 58. And here's the problem with this approach to medicine that we're taking right now. The tests that he had and the drugs that he took could not and did not address what killed him, which was miles of rotting arteries lined with unstable plaques. One of them ruptured and caused the heart attack that killed him. Now, some people have said to me, well, Dr. Pam, you're a naturopath, and that certainly would have caused you to recommend something different to him. Yeah, I would have recommended that he change his diet, but what they're getting at is supplements and alternative treatments. And I call myself a recovering naturopath, right? Every day I pull into the parking lot of my office, try to forget what I learned so I can be helpful to people. Because had I given somebody like Tim Russert high-dose cinnamon for his pre-diabetic condition, high-dose niacin for his cholesterol, and hawthorn berry for his blood pressure, he'd still be a dead guy with better blood work, okay? And that's not the end point, you guys. That's not the end point we're looking for here. Here's an informed consumer, better outcome, an informed, happy ending. Not because of medical intervention, however. Take a look at Bill Clinton. This is what amazes me about the Bill Clinton story. The best, air quotes around that, physicians in the United States of America take care of the president. And the best physicians in the country watched him eat cheeseburgers and French fries. He was known for it. While his health he descended into worsening heart disease, finally had a bypass surgery. It didn't work. He ended up in the hospital and had angioplasty. And then he later explained on the Wolf Blitzer show, and I think this was back in 2009, that he was scared half to death after those arteries closed up again. So he read the China study, he read Prevent and Reverse Heart Disease, and he fixed himself. He took matters into his own hands. And that's perhaps the most important message of all here, is stop outsourcing your health to people who don't have a horse in the race. You are the one who benefits or suffers based on the decisions that get made. So wealth doesn't protect you. I said earlier my mother wouldn't listen to me. She was a wealthy, educated woman. She just didn't want to hear about this. Wealth doesn't educate you. Insurance wealth doesn't protect you. Insurance doesn't protect you. The best doctors don't protect you. What protects you is you doing the research and learning about the stuff and making better decisions. Okay, so which would you choose? Informed decision-making leads to better choices, and it's fortunately not limited just to cardiovascular disease. We can have the same discussion about so much else that goes on in medicine, like diagnostic testing and flu vaccines and psychiatric drugs and musculoskeletal pain, dietary supplements and advice, any and all health-related matters. Let's face it, if people saw informed information before choosing which diet to adopt, nobody would eat a paleo diet. Atkins never would have had best-selling books. And the Zone wouldn't have food products in every store, because an informed discussion about the benefits and risks of those diets would have led to an inevitable conclusion, which is that a plant-based diet is the best option for avoiding disease. So I'm going to touch on each of those categories just real briefly. Peter Goetschke is the author of Mammography, Truth, Lies, and Controversy. He's co-founder of Cochrane, Denmark, again, the most independent medical research organization on the planet. And this is a must-read, I think, for every woman. It's kind of a tough book to read. It's long and it's scientific, but it's worth reading. And one of the reasons, by the way, he wrote the book, and he's written 3 others now about other topics, but he said it's getting harder to get good information into medical journals. It's one of the reasons he's decided to take the approach of writing books, because it's easier to get books in Barnes & Noble than it is to get good articles published in the New England Journal of Medicine. So let's take a look at mammography. And this goes to why it's so important to be an informed consumer, because this next section goes to this point. If you are convinced after what I showed you about coronary artery disease, all right, I'm going to eat a plant-based diet, I'm going to do as Dr. Esselstyn's diet because I don't want to die of heart disease. But if that's what you do, and you're not careful about things like being drawn into the medical mill, being tested for things that you shouldn't be tested for, subjecting yourself to treatment for other things that you shouldn't, you may not do any better. So it's important to look at all these issues. So let's take a look at mammography. Here's the problem with mammography. It's an unreliable test. It's very good at detecting small masses that are not likely to turn into anything like ductal carcinoma in situ, and not very good at detecting cancers that are likely to kill you. We call them interval cancers. They're the ones that develop in between screenings. And those are the ones that kill women. They grow very, very quickly. So one of the problems with mammography is, first of all, there's $8.3 billion worth of mammography being done in the United States every year, so they're not likely to give it up. It's very profitable. But another problem with mammography is it's being used because of statistical manipulation to prove that it's valuable, because if you diagnose a bunch of people who don't have cancer, you treat them for a cancer they don't have, and they're all alive 5 years later, which they would have been anyway if you just left them alone, and we call them survivors. It makes the cancer industry look like it's doing much better than it actually is. Okay, so it's a very perverse system we've developed here, where something that doesn't work can be used to show that it works by just manipulating statistics. All right, let's talk about ductal carcinoma in situ for just a second. Ductal means the cancer starts inside the milk ducts. Carcinoma is any cancer that begins in the skin or other area of the body, covers or lines the internal organs. In situ means in its original place. It's non-invasive because it hasn't spread outside the milk duct. It shouldn't be classified as cancer since it's just a clinical abnormality, but we call it cancer anyway. Studies show that women who have DCIS only develop full-blown invasive cancer 18% of the time. And here's what's even more interesting. That percentage is lower in areas of the world where women eat a better diet. Okay, so it's as low as 11%. Furthermore, the time it takes for ductal carcinoma to grow into something invasive for the small percentage of women who that actually happens for is many, 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 many years, which means that active surveillance would be a better idea. Actually, the better idea would be not finding out about it at all, don't have the mammogram, but active surveillance, which is watching what happens. So think about if we insist on doing this test, which I can make a strong argument against, women who are diagnosed with ductal carcinoma in situ took it as a warning sign. Perhaps they should change their ways, eat better, eat an optimal diet, exercise, lose weight. We'd have the breast cancer rate would plummet. Okay. Instead, women have surgery, they have radiation, they take aromatase inhibitors. Many of them have chemotherapy, and an increasing number of them even have a mastectomy, because a bilateral mastectomy, because they're so frightened about cancer. And people should be frightened about cancer, by the way. I'm not suggesting that they shouldn't be. I'm just suggesting they should do something different about it. Cochrane collaboration showed that, a review showed that for every 2,000 women that you screen over a 10-year period of time, only one would have a longer life and 10 would be harmed. And they came to the conclusion that there's no evidence to support screening women at any age. A study in Denmark actually showed, comparing areas of the country that do and don't use mammography as a screening tool, showed that women who had mammograms actually had an increased risk of cancer rather than a decreased risk of cancer. It wasn't statistically significant, but it certainly didn't show that mammography was beneficial. This study basically showed that the false negatives and false positives are a problem. Obviously, a false positive, you can have more diagnosis over treatment, scare women half to death. False negative, be told you're okay when you're really not. But the study said we've got to be extremely careful because of radiation-induced breast cancer from treatment. Now, how would you like to find out that you had breast cancer that was caused by radiation that was used to treat you when you didn't have cancer in the first place because you had DCIS? Okay? This is really disturbing, and I hope people are disturbed. 1,050-year-old women screened for 10 years. Between 490 and 670 of them will have at least one false alarm. It's a huge number of women. Between 3 and 14 will be diagnosed and overtreated. 0.3 to 3.2 women may avoid a breast cancer mortality. So the risk of being harmed is 3 times greater than the risk of being helped. I think women should know this before they have a mammogram. False positives increase the number of mammograms, number of biopsies, estrogen treatment like birth control or HRT, and the individual radiologist's tendency to diagnose breast cancer. It's highly subjective. And study after study after study has been done to try and take the subjectivity out of it without success. Compression of the breast tissue can actually cause breast cancer. If there is anything contained, it can cause it to spread. And 3 studies I've listed here show that. Studies even show that mammography doesn't change the outcomes for women who have the gene mutations that predispose them to develop breast cancer. In fact, we now have long-term outcome data that compares women with the gene mutations who do and don't have prophylactic mastectomy. You know, the death rate from cancer 10 years out is exactly the same. Now, they don't die of breast cancer because their breasts have been removed, but did you know, for example, if you have that gene mutation, you have an equally increased risk of having pancreatic cancer. We can't take your pancreas out. How many organs can we remove? Okay? We've got to start talking about prevention from an entirely different perspective because this is not working. So the U.S. Preventive Services Task Force came out with a statement in 2009, and these guidelines are still not being followed. And that basically they said, listen, the risk for mammograms for women between the ages of 40 and 50 outweigh any benefits. Okay, so we should stop doing that. Women between 50 and 74 should get a mammogram every other year. No evidence for mammograms after the age of 74, and breast self-examination is useless. Okay, so women screamed and hollered and said, you know, everybody gets very defensive. They're trying to ration medicine. I think we should ration ineffective medicine. I think you should have to really scream and holler and demand medicine that doesn't work. Okay, I know this doesn't work, but I demand to have it anyway because I just love hanging out with doctors and going to hospitals, right? I don't think we'd have many takers if that was the case. Well, after that came out, this really should have been the thing that ended it all. About 90,000 women were randomized to have either regular mammogram or just breast exam by trained nurses and health professionals. And after 25 years, the researchers determined there was no benefit from having mammograms. This was a 25-year study involving 90,000 women. We can't complain about the period of time. We can't complain about the size of the cohort. And this doctor said this is going to make women uncomfortable, and it should. We have to have the uncomfortable discussion that what we're doing is not working. So in 2015, the U.S. Preventive Services Task Force came out with an updated recommendation, and this time their language was much stronger. They said in order to save 4 lives, 10,000 women have to be screened for 10 years. This is a ginormous number of mammograms that have to be done to save 4 women. And then in the meantime, the false positives, the false negatives, 99% of the time the biopsy shows no cancer. Where in the world can you do something where you have a 99% failure rate and stay in business? Okay? It's ridiculous. And then the chairman of the committee said, mammography is good and it's useful, but boy, does it have its limits. And so why I've shared this with you is people say, well, if mammograms don't work, what am I supposed to do? Women will be terrified. They should be terrified, but not in the way of feeling helpless and victimized, because what do you do if you don't want to get breast cancer? You eat an optimal diet. You take off the excess weight. You start exercising. You do everything you can to protect yourself against the disease. And if the medical profession would just look women in the eye and say, look, we do not have a diagnostic test right now that will catch the cancer early. So you better start working on how you live your life, because that's the only way you're going to protect yourself. I think women would become more motivated to do it. Now, because people have been brainwashed for years and years and years to think that the solution to everything is early detection, people look at me and they go, well, are you sure? Are you 100% sure that if I do all the right things, I'm not going to get breast cancer? Well, there is no such thing as a 100% guarantee, but here's how I explain this to the people that I work with. Taking care of your health is a lot like driving a car, okay? So here's the way I handle driving a car. I have a good car, and I keep it in good working order. I have insurance. I put my seatbelt, I buckle my seatbelt. I drive the speed limit almost all the time. Okay. I stop at stop signs. I observe the traffic signals. I try to keep my eye open for kids running into the street and other things that can happen. It's the best I can do. Am I guaranteed that I'm not going to be in a car accident? No, because driving home from work someday, some idiot can run a traffic light and wipe me out. But I can't worry about that. I can only worry about the things that I actually have some control over. And what I have some control over is a car in good working order, fastening my seatbelt, observing the traffic signals, and trying my best to be safe. That's it. That's what I can do. So we seem to be able to drive cars and do all kinds of things that have risks associated with them, fly in airplanes and that sort of thing, without being obsessed all day about what kinds of risks we're taking. And I think we need to carry that behavior over into looking at how we handle our health. You do the best you can, and then you just go live your life. And if something bad's going to happen, that's just the way it is, all right? But instead, we keep thinking there's something outside of us that will save us from ourselves and our own bad habits. And that just plain is not going to happen, okay? Prostate cancer. Let's talk about, we have to give men equal treatment. So we talked about diagnostic testing for women. The most common test that leads to disaster for women is mammography, closely followed by DEXA scans, most useless test we've come up with for bone health. Prostate cancer kills about 30,000 American men every year. But what's very interesting about prostate cancer is if you look at it worldwide, most men die with prostate cancer, but they don't die of it. About half of men over 60 have prostate cancer. After age 70, 80% of men have it. The older they get, the more likely you are to find it. But the question is, does it really make any difference to know about it? Most men will die of other things. Now, Dr. Richard Ablin is the researcher who discovered prostate-specific antigen. He's a personal friend of mine, and he spoke at our last conference in November. And a few interesting things about this. First of all, PSA is a normal product of the prostate. It's not prostate cancer-specific antigen, it's prostate-specific antigen. In other words, it tells you you have a prostate, which most men know before they show up in a urologist's office, I think. The result, we have a lot of tests like that. You know, that's the DEXA scan basically diagnoses you with aging. How many people did not know they were growing older before they came here today? Yeah. So anyway, according to Dr. Ablin, he's devoted the last 20 years of his life trying to convince the FDA, public health authorities, that this is a useless test. It has very little usefulness for anything. The result of the test is slightly better than flipping a coin, not much. Okay, so the PSA test, all kinds of things can go wrong. Different labs read them differently. Human error is a factor. The highest normal has been determined to be 0.4. Some urologists say 2.5. And this is another thing that's going on in medicine too, is we keep changing the diagnostic parameters for disease, which means that more and more people are getting diagnosed earlier and earlier. And do you remember what I said earlier about the smaller the abnormality, the less likely you are to benefit from treatment? One of the problems we have in our office when people come in is the first thing we have to do is figure out if there's actually something wrong with them. Because we have a strict rule in our office that we don't treat disease that doesn't exist. We just think that's a good rule to have, right? So, yeah. Seems like it would be obvious, but actually not so much. All right, so the lower the threshold, the more diagnoses you're going to get, which is good for the medical profession, not so good for the people being diagnosed. And so one of the things that Dr. Ablin says, and he wrote a great book, The Great Prostate Hoax, strongly recommend that you read it. By the way, he also created a documentary, or was involved in producing a documentary called The Second Opinion. It was supposed to be shown on television. Does anybody want to guess why it was never shown? Who are the biggest advertisers on broadcast network? Yeah, the drug companies, the device makers, and that sort of thing. So we showed it at our conference, and he got a standing ovation at the end of the conference. But those kinds of things will never be shown on TV, and thank you, Steve, for making this available this way. Seriously. I don't think I have to tell you this, but Steve does not take money from the pharmaceutical companies. So anyway, what Dr. Ablin says is that the test is meaningless. In other words, a guy who has a PSA of 0 could actually have aggressive prostate cancer, and a PSA of 11 doesn't really mean anything. So what kinds of things can affect the test? Travel, jostling in cars or trucks, buses, whatever. Exercise, especially bicycle riding. sex, benign prostate hyperplasia, age. PSA increases with age. That's another thing that's happening, is we're diagnosing a lot of people with disease merely because their markers change as they age. We don't take that into consideration. Urinary tract infection. The bottom line is that lots of different things can affect PSA and the reading. So the lifetime risk of being diagnosed with prostate cancer in the United States is 17%. The lifetime risk of dying is 3.4%. You see what we have is an epidemic of diagnoses, all right, due to exposure to urologists. That's a leading risk of prostate cancer is exposure to urologists. And the problem, part of the problem with all this diagnostic testing is, first of all, it leads to overtreatment. And it leads to overtreatment because we like to, urologists like to do surgery. That's what they're trained to do. These centers that offer mammograms, they also offer breast cancer treatment. So it's a system for recruiting patients. But there's another thing that's going on too that I think we have to realize, and that is that the way that human beings are wired, it is difficult for them to put out of their minds that they have an abnormality. It's much easier to say, just do something about it. I don't want to do watch and wait. I don't want to do active surveillance. The thought of living with this thing, whatever this thing happens to be, is a major problem, and I just want to take care of it. So it reminds me of, does anybody know who Gilbert Welch is? He's a medical doctor who's written some great books like Less Medicine, More Health, and Should I Get Tested for Cancer, Overdiagnosed. And one of his books, and I don't remember which one because I've read them all, he starts one chapter by saying, he says, I think I am in good health. And I think one of the reasons I'm in good health is because I think my health is good. And if I start having a lot of tests done and I find out that something is wrong, even if it's small, it will chip away at my idea that I am healthy, and it will therefore lead to bad health, okay? And what he was talking about was the idea that we always think more information is better. I don't necessarily think so. And I do like more information about a lot of things. I do a lot of research. I'm writing a book right now based on the new film that I'm in called Food Choices, and lots of research involved in all kinds of things. But you know what I don't want to know anything else about? Me. Okay? I do not want somebody poking and prodding around in my body trying to find something wrong with me, because I'm 60. I will be in a few weeks. And I'm pretty sure that at this age, you can probably find something wrong. But I'm really not sure it benefits me to know about it, right? Now, that doesn't mean that I would never go to a doctor. I mean, if I had a pain in my side and it didn't go away by Monday, I'm not an idiot, all right? I would go find out about it. But the problem that we have is medicine doesn't do that anymore. What we're doing is we're plucking healthy people out of their family rooms and backyards and drafting them into testing programs with the idea that the more we find out, the better off we are and they are. And actually what we're doing is we're turning healthy people into sick patients, and many of them aren't even sick. So we have a couple things to talk about. What do you do for the sick people? Well, that was the first part of this presentation. What do you do if you actually have coronary artery disease? The second part of it is, how do we keep healthy people from being labeled as sick people? Because let's face it, if all that stuff I showed you is bad for a sick person, how bad is it for a healthy one? All right? Even worse.
What was that doctor's name?
Welch, Dr. Gilbert Welch. He's and he has, I think there are 4 books he has out now, all really, really good. And he writes a lot of great articles that appear in the op-ed section of the New York Times and that sort of thing. And Welch is another one who doesn't take money from anybody, so his opinions are his own. And I agree with him on most things. He's not so geeked up about the diet and lifestyle stuff, but he has a really good way of analyzing data and helping people to know how to be cautious about medicine. I think that's his primary message. So anyway, the bottom line with prostate cancer is if you want to avoid overtreatment, stay away from urologists and PSA testing. The problem that we have is that PSA test is often done as part of a normal blood test. Men don't even ask for it anymore, and they find out that they have a higher PSA, and again, we go through the whole discussion about, do you really have anything wrong with you? And that goes to one thing that goes to the point that I was making earlier about disturbing people's sense of well-being is I have a person in Columbus who consulted with me about this. Interestingly enough, right before Richard Ablin was going to spend time in our office in Columbus, that was very helpful to this particular gentleman. But anyway, he looked at all the information, and I have 5-6 hours worth of prostate cancer and PSA testing information. And he looked at all of that, and he said, I'm not going to pursue this. I'm not going to get a biopsy. I'm going to try to put this out of my mind. And he did, except that every once in a while, I see this guy all the time because he comes in and out of our place to take yoga and some other things that we do there. Every once in a while, he'll pop his head in the office if my door's open and say, I'm going in for a checkup, because for insurance where he works, he has to have a checkup. He goes, I know this discussion's going to come up again. He goes, I just need you to tell me I did the right thing, right? I said, well, you don't need me to tell you that. You need to tell yourself that. He says, I know, but I just get this, that funny feeling. And it goes to the fact that humans don't live well with the idea of an abnormality. So that's I think, an important thing we need to consider about all this testing. Okay, let's go on to flu vaccines, all right? Yeah, because I always try to avoid controversy whenever I can. But Cochrane collaboration. First of all, the flu itself rarely leads to death. The data have been so manipulated by the Centers for Disease Control to make it look like flu kills people. It actually really doesn't. At best, vaccines may be effective against a particular strain, and it may not be the one that's going around that year. You have to vaccinate 40 people to prevent one case of flu. 71 people, or flu-related illness, 71 people need to be vaccinated to prevent one case of actual flu. No effect on days lost from work or hospitalization, no effect for pregnant women that's known, no effect for their newborn. Now, what I've always thought about flu vaccine, it's interesting, if you go to the CDC's website and you just put in the search engine flu vaccine in pregnant women or vaccines in pregnant women, it is unethical to put pregnant women in clinical trials for vaccines. Can't do it. Unsafe to find out. It's perfectly safe for every OB-GYN in the country to tell pregnant women you should have a flu vaccine. It's not safe to find out, but it's okay to tell you it's okay. All right, that bothers me quite a bit. So anyway, I think we can write that off as useless. The Cochrane collaboration has further said the vaccine is useless for all people of all ages. It doesn't benefit anybody. Psychiatric drugs. This information comes from one of my business partners, Dr. Peter Bregan. He's a psychiatrist in Ithaca, New York. In 50 years of practice, he has never prescribed a drug to a patient. He has never institutionalized a patient. He has never had a completed suicide on his watch. He's written 20-some books on the inadvisability of drugging people and how to deliver effective therapy. And we are business partners in that we are developing right now, which will be ready in January, a mental health program that does not involve drugs and does involve how to withdraw people from psychiatric drugs through our healthcare company. Anyway, just so you know, there's not a single study that has ever shown that there's any such thing as a chemical imbalance in the brain that causes disorders like depression and anxiety or ADHD. Now here's why there has been no such study. Because it's unsafe to conduct such a study. The damage that you would cause permanent brain damage in anybody that you tested to the extent that you could even figure this out. The study that has launched this whole thing about treating chemical imbalances in the brain with drugs, purported, was one that was done on rats that appeared to be depressed. Now, has anybody ever wondered how you find out if a rat is depressed? Yeah. This is serious. This is what they did. And upon autopsy, they ground up their brains, and they found out that the rats that appeared to be depressed had lower serotonin levels. And that is the basis for this whole thing that we do right now with drugging patients who have psychiatric disorders. Clinical trials showed that the drugs were no better than placebo. Meta-analyses done by people like my friend Dr. Peter Bregan have shown that they are harmful and useless. They increase the risk of suicide and violence. And in fact, the clinical trials, they could not include anybody with suicidal ideation or with violent tendencies because they knew at the time. Every one of these violent acts, Sandy Hook, Columbine, committed by people taking the drugs, okay? 25% of Americans take the drugs, 25%. All right, so useless, basically. Harmful, useless. It's harder to get somebody off of Xanax than heroin. I'm not kidding. We have to do this in the office all the time. Orthopedic procedures, same thing. When you go to see an orthopedic surgeon, a lot of times they do imaging to determine the source of your problem. And they often find abnormalities. The problem is there's no relationship between the abnormalities that show up in the images and the pain that the person's having, which is why spinal fusion surgery doesn't work. Knee surgery doesn't work. One of the most famous studies that was published in the New England Journal of Medicine, they did sham knee surgery. And how you do that basically is you numb people, you open them up. Some people get the real deal, some people, no difference in the outcomes 4 years later. None. Okay? So there's a great book written by Dr. John Sarno. We use his program in the office called Healing Back Pain. He basically said this business of being in pain for years and years is ridiculous. Human bodies are strong and resilient. That's another thing we have to get across. The medical profession has made people think that their bodies are weak and fragile and subject to breakdown and breaking, when we actually have incredibly strong, resilient bodies that are able to withstand enormous amounts of stress and recover from serious disease. I mean, you see it in a lot of the documentaries out there, people who have, terminal cancer, and they don't die, And speaking of that, by the way, a colleague of mine, good friend, Kelly Turner, wrote a book called Radical Remission. Any of you read it? It's the first study that was ever done on terminal cancer patients who lived. She interviewed 1,000 of them and determined what they do to stay alive. They used 74 strategies, 9 of which were used by all 1,000 people who didn't know each other. And guess what the first one is? Dietary change and a plant-based diet. She actually referenced China Study and Colin Campbell in the book. So, Radical Remission. Kelly Turner is her name. She spoke at our conference last year too, and just her talk was riveting. And think about terminal cancer patients, they think they're the most fragile of all. Think about how powerful you are to overcome stage 4 pancreatic cancer. And it's the book is the roadmap on how to do it. And the first thing is you decide, and the second thing is you become incredibly convinced of the incredible power of your body. And that's the opposite of the way medicine makes people feel. They should feel empowered, not like helpless victims. It's a very terrible system we have from just the mental health idea of this. So anyway, Sarno wrote his book, Healing Back Pain. He thought that what people needed was not surgery and physical therapy. They needed what he called knowledge therapy. Show them how strong their bodies are and tell them to get out there and start moving around. And in 6 weeks, most of them were cured. And I have, over the last few years, met several of his patients who said, I was walking around thinking I was going to be crippled and I spent 6 sessions with Dr. Sarno, went back home, scrubbed the floor, washed my car, weeded the yard, and never had that happen anymore after that, right? So we need to convince people that their bodies are actually strong. I want to talk just a tiny bit about supplements, because this is another area of misunderstanding. Again, if people looked at the medical literature, they wouldn't take so many of these things. U.S. Preventive Services Task Force actually issued a statement saying that the reason why so many studies show vitamins to be useless is because apparently nutrients in food are a lot better for you than taking them out of food and putting them in pills. Wow, right? Don't you love it? The statements of the obvious, Antioxidant supplements. Cochrane did a review. They did, this one included 67 randomized controlled trials and concluded that the supplements were useless. It's different when you consume them in food than when you consume them in pills. Now, omega-3 supplements, and I'm not going to read these studies to you, but I'm just going to show you here. This one is a meta-analysis of 48 randomized controlled trials. Conclusion, useless. 20 studies, 68,500 and some participants. Conclusion, no difference in any measurement. 14 randomized double-blind placebo-controlled trials, useless. Fish oil, useless. But it goes on. Okay, so a survey of health practitioners, most of them were holistic and integrative, 95% said they were still recommending omega-3 supplements to patients. And you know why? Most common reason was for heart health, 82%. All those studies that I just showed you were measuring mostly heart health. Now, the reason I'm showing you this, is that I am critical, very critical, of traditional westernized medicine. I am also very critical of the holistic, integrative, naturopathic approach to medicine too. I'm an equal opportunity critic, so I stand in the wonderful position of having the traditional medical profession, not all of them, but as an institution, hate me. The naturopathic community hates me because they think I betrayed them, because I walked away and said I'm a recovering naturopath instead of buying into their dogma. And so as I show you this, the key is, this is why it isn't about finding just an alternative doctor. It's about developing an alternative mindset, which is evidence drives the decision. I don't care if you're talking about taking an omega-3 fatty acid supplement or having a mammogram or how you're going to approach cancer treatment. Evidence drives the discussion. And it doesn't matter which initials are after somebody's name, MD, ND, Ph.D, RN, NP, pick some from the alphabet soup. If they don't follow the evidence, this person cannot help you. Okay? Now, the reality is, most people in medicine, regardless of the initials after their name, are not following the evidence, so you have to learn how to follow the evidence. The happiest days in my life are the days when my people call me, the members of my practice call me, and say, I am so proud of myself. I sat down with my oncologist, who's the head of the department at this very prestigious university-based medical center, and showed him in statistical terms why he's wrong about what he's telling me to do. That makes my heart sing. It's the reason I get up in the morning. Because this battle we're fighting for medicine, it's not going to get solved by hoping that guy's going to change his mind. It's going to get solved by consumers changing theirs. That's the key to this. So I want to make sure we have some time for questions, because I think you might have a few after all this. So this is my favorite quote. I use this in a lot of my presentations. While patients are grateful for new drugs and operations, what they really want is not to be patients at all. In this, we're failing them. And I think that's really the truth. I mean, many people, most people have allowed themselves to be sucked into the medical mill. And that's not where they want to stay. They're looking for optimal health. They're not looking for a better way to manage their symptoms and stay sick. But that's not what medicine delivers. So let's talk for a minute about how not to be a patient. And the primary thing you have to do is you have to start practicing proactive and intentional medicine instead of what I call reactive and episodic medicine. So reactive and episodic medicine means this. It's this mentality that I can eat, drink, and be merry. I'll get sick at some point in time. I'll take a drug or have a procedure or do something that somebody else will do to me from outside me to fix me, and then go home and I'll keep doing the things I was doing before. That's how Bill Clinton ended up in trouble. Continuing to eat cheeseburgers after the bypass surgery, as it turned out, not a good plan, okay? And then we just wait for something else to happen, and that's the way people live their lives. And I saw this myself. I've lost friends this way. Very wealthy couple that I've been friendly with for years. He died about 1.5 years ago. Here's how it happened. About 10 years ago, he started putting on weight. And he's known what I do for a long time. And he always used to joke around and say, I should listen to you. And I used to say, yeah, you should, but he didn't. So he started putting on weight, and he got to be pretty rotund. And then he had a blood clot in his leg, and they fixed that. And then he developed type 2 diabetes. There are medications for that. None of this registering at all, okay, other than the occasional, I know I should be listening to you. And then he developed stage 4 pancreatic cancer, and you've never seen such a conversion in your life. I'm ready to do anything. Tell me to eat grass in the side yard. I'm in, okay? Well, I'm really good at what I do, but I am not a magician. And that's what it takes to fix something like that at its very late stages, and in 4 months he died. So what killed him? It really wasn't the pancreatic cancer. It was ignoring all of the things leading up to the pancreatic cancer. Now, he died. What happens to a lot of people is they grow old, and every year they take a few more medications until they wake up one day when they're 82, and they're taking 15 medications, and you've seen people walk around with their pill boxes. And it's so unusual to see people in their 80s who don't take medications that people can't even believe that it's a possibility. My dad's 85 and he doesn't take meds. He works at Wellness Form Health 3 days a week. And he's the company proofreader. The reason why you don't see so many typos in my stuff now is my dad's like in the next office writing herd on my writing style. So anyway, once in a while he'll do one of these clinics at a shopping mall, has a health fair or whatever. And I'm going ahead and take my cholesterol. His IQ is higher than his cholesterol, by the way. But anyway, going ahead and take my cholesterol, and they'll say, how many, what meds do you take? And he'll say none. And they'll say, sir, I was asking you about medications. And he goes, I'm not deaf. I don't take any drugs, But nobody sees people in their 80s not taking drugs. So, it's such a shock. But that's how people end up this way, this reactive, episodic approach to healthcare where we just wait for things to go wrong. Proactive and intentional health is where you decide that health is a priority. And I want to talk about that for just a second, because I think part of the problem, part of the disconnect, is that people have decided, some people, that health is a priority, but they have established it as an end in and of itself. I want to achieve optimal health. Okay, I do too. I think I have it right now. But that's not the thing. It's what that thing gives you. Optimal health gives you longer life, better quality of life, more time with family and friends, more time and energy to pursue the things that you want to do, like travel and read and cultural events. And, people like me, I can't get enough of anything I do. I have this disease called FOMS. It's called fear of missing something, all right? So if you want to live your life that way, you're going to have some health to make it happen. So we have to talk about optimal health, but I think we have to take it a step further, and we have to talk about what optimal health gets you, because that's what motivates people. People are more motivated to go take a trip to Europe than to have lower cholesterol. Let's face it, lower cholesterol is how you get to live long enough to take that trip. So anyway, you make health a priority. You resolve the health issues you have to the best of your ability, and then you work at maintaining your health like you maintain your car, like you maintain your house, like you maintain anything else that you have decided is valuable to you. That's how you practice proactive and intentional healthcare. And in order to do it, you're going to have to practice informed medical decision making. Because if you just show up and do what you're told in medical offices, you'll end up in a lot of the types of trouble that we've been talking about through this whole thing. So that is informed medical decision making. It puts the consumer in control. And people say, that's a great idea, but it's too complicated. Medicine is too complicated. Well, here's what I have to say about that. We all do things that are complicated. We buy things that are complicated every day, and we somehow manage to get enough information in order to make a decision. Now, I don't know about you, but I have no mechanical skills at all. I do not know how cars run. I know that when I put my key in and turn, the car comes on. I know how to turn it off, and I know how to call a mechanic if that doesn't happen. Now, that's the extent of my knowledge, but I've been buying cars for 40 years. Somehow I've managed to do that. How many of you have bought a house? How many of you know how to build a house? A couple. Okay, so how did the rest of us actually buy a house without knowing how to build a house? You get enough information that you don't have to know how to build the house to get enough information to decide if this is a good house to buy or how to evaluate that. And the same thing is true about medicine. Everybody can be taught to read studies, to interpret information, and to become an informed consumer. And I would say it is as important, probably a lot more important, that you do this with your health than you do this with your car and with the other things that you own. So with that, I'd be happy to take some questions from anybody who has one, and I'll repeat them for the audience that's streaming in. Yes?
So are you against any kind of supplements like turmeric or inflammation?
Well, let me say, first of all, the question is, are you against any type of supplements? I'm not for or against anything. Let me say that for the record. I'm for looking at evidence when making decisions. And supplements, in my opinion, are the same as drugs. In other words, they are useful for specific populations, but there's no money in that. We have to make them useful for everybody. And furthermore, the taking of supplements is often a distraction to solving the real problem. In other words, and this goes to my naturopathic training and why I've left it behind. So if you go to let's say you have arthritis, you go to a traditional doctor and he prescribes a COX-2 inhibitor. Well, Vioxx was a COX-2 inhibitor. We know what happened with that. It wasn't such a good idea, right? The allure of drugs is you solve the problem right away. The bad news is, I don't know, a few thousand people tens of thousands of people died of heart disease. Okay, so somebody knows that now and says, I'm not doing that, so I'm going to look up the local naturopath. I'm going to go see her, see what she has to say. And the naturopath says, well, we don't prescribe COX-2 supplements here. We find that glucosamine helps most people. Okay, it does actually. It doesn't work as fast as drugs. Here's what the problem is. The person still has arthritis. All right? We are just covering it up with different stuff, and my stance is that the evidence is pretty clear. We're better off not using any stuff and fixing the problem. Okay? So the issue is that when better options are available, the supplement taking has turned into a different form of drugging, and I'm opposed to that. Other questions? Yes. Okay.
I thought the thinking was that oftentimes because of the deficiency in the food, in the soil, the food, the quality of food, the processing, that we're really not getting many of the nutrients that when we eat well or think we're eating well, not to even consider half the time we're not eating well. So I thought that was kind of the rationale for some supplements.
Well, let me address that. It's a good question. The first thing is that if you want to sell supplements alleging that the food's deficient is a good way to make your case. The problem is you can't really prove it in terms of evidence. But I'm going to go back one step further. You're talking about making up for not eating well. You cannot make up for your dietary indiscretions by taking 11 pills every day, or 2 or 19. And that's what these studies are showing, because these studies, like the ones I showed you on omega-3, they're taking everyday people who eat crap and giving omega-3 supplements and seeing if a pill will make up for all the bad eating. And it's not shocking to find out that that doesn't work. It doesn't work in the drug business either, all right? So the only way, and we've got to get away from thinking that there's some solution, and people say this to me sometimes, well, what are you going to say to the person who won't change their diet? Well, we don't have anything for you. I mean, think about it. If you went to a financial planner and said, I want to retire rich, but what do you say to the people who won't save money? Financial planner would say, I don't know. I mean, if you're going to continue to spend more than you make, and I don't have a solution for you. Okay, but let's get to the deficiencies in the soil and all that. My colleagues have been conducting studies. Esselstyn's one of them. McDougall's published studies. And there's no requirement to eat organic food, even. Just go out and eat all that deficient food you can get your hands on in the grocery store, and the heart disease is going away, and the diabetes is going away. And I think that proves the point that while we can all agree that current farming methods are terrible and they need to change, and there's a lot about that in Food Choices, my new film, it is not to the place where people cannot be nourished from the food. The evidence just doesn't support it. So that goes to why you have to carefully evaluate everything you're being told, because a lot of this stuff sounds like it could probably be right. It just isn't when you finally look at it.
Hi there.
Hi.
3 years and 3 months ago, I got diagnosed with a very scary diagnosis and panicked and freaked out. I happened to find the right people. But for somebody that doesn't find the right people, what book or film or what would you recommend? Where would they turn to have a clue of what to do? Because there's just not enough information when somebody's going to a general medical or surgical person.
Well, that's a good question, and I think I'm kind of partial to the books and films I write and I'm in. Just have to put that out there. Obvious bias. You're supposed to disclose your bias. I like my stuff, but anyway, you're right, and that's why we're doing a lot of what we're doing. We own a school. We're training health professionals. We're re-engineering health professionals. Our goal is to build our own network to 100,000 health professionals and solve this problem, and we're on our way to doing it. But in the meantime, the way that people find anything is asking around and research. Who do you know? Who do you know? Who do you know? People ask me all the time, how do I find a good doctor that I can talk to? Start asking your friends. And it doesn't matter if it's a plant-based doctor, it matters if it's a good doctor. And what I am so encouraged about right now is, as much as I scream and holler about medicine, what I am loving these days is, first of all, doctors are sending people to me. And the second thing is, it used to be when I would say to people, so if you talk to your doctor, you're going to change your diet and some of these drugs are going to go away, and people would say, yeah, I told him I was coming here and he told me you were a quack and to stay away from you and tried to scare me out of even showing up here. That doesn't go on anymore. More often than not, what I hear is, yeah, I told my doc I was coming in, she can't wait to hear what I bring back, and ready to talk about it. So there's a lot more cooperation. So if you don't have a doctor like that, what you do is you start asking around, who do you go to? Does your doc talk to you? And this serves a couple purposes. First of all, people will find the good ones. And the second thing is, the good ones will get well known for being good, and they will dry up demand for the bad ones. The bad ones will go out of business, which is what we want, right? So you start asking around, you start getting online, you start looking at resources, just the way you would solve any other problem. Okay, if somebody told you tomorrow, you're moving to Madrid, Monday, all right? You don't know anything about Madrid. You ever been there? No. Okay, all right. But you're going to have to figure out where to live. You're going to have to figure out how to get yourself there. You're going to have to figure out whether or not you're going to buy a car. All this stuff that you don't know anything about. How are you going to find out? You're going to get online. You're going to remember somebody you know who'd been there, and you're going to figure it out. And that's exactly the way people figure this out. The problem is they don't think about medicine the way they think about everything else they do in their life. What I'm basically asking people to do is apply the same principles that govern everything else you do. Apply them to this. Okay?
So if you were going to, I like the way you started with making informed decisions. It's helping people think about their diet. So if you were riding an elevator with someone and you had that amount of time and you wanted to make your argument, have you ever done something like that, kind of consolidated it?
Well, I do that, but I'll say to you that I don't approach people in elevators, and for a variety of reasons. But here's what I learned early in this. I've been in this business for 20 years. And I think all of us start out, when we start getting this information, we have great intentions, unbridled enthusiasm, and desire to share, okay? Otherwise known as lecture. And there are still people in Columbus that if they see me in the shopping mall, they duck into the jewelry store, hoping not to make eye contact, because what they don't want me to do is come bounding across the mall to jump on them and give them a lecture. So I really learned to back off a little bit, a lot actually, and I do what's called waiting for teachable moments, which is when people ask me things. And then I can give a simple answer that isn't like, this is my chance, I'm going to jump on the dinner table now, snatch the steak away from you, and show you the way this is done, right? But waiting for teachable moments and then talking to people and trying to interest them in learning more information. And making sure I'm really detached from the outcome, because that's what gets us in trouble all the time, is when we're just determined to make people see things our way. It doesn't really matter what we're talking about, diet, politics, whatever. and then just take it from there. And in 20 years, what I've seen is that if I do that, first of all, people are not afraid of me anymore. The second thing is I can invite them to events. We do dinners and things in our office, and I can get people to come once a month, and that's a chance for me to tell the story somewhat like I've told it to you guys here, and let them hear all about it, make up their mind what they want to do. And then what's really made me happy over the years is the number of people who are close to me and I care about who have decided to change. My dad's one of them. A couple that I've been friendly with for years, they've supported me in everything I've ever done, including this, never been interested in this. Another couple that joked about it all the time. And they're both eating a plant-based diet now. And she's become the gourmet cook of Indian Lake, Ohio, and gourmet vegan cook of Indian Lake, Ohio. I mean, those kinds of things are wonderful things, and you just have to wait for them to happen. You can't force it. Yes?
Two topics. One of them is for women, osteoporosis. We're told we should take 1,200 milligrams of calcium a day, which no matter how many greens you eat, you're not going to get anywhere near that. So the bones and osteoporosis, and then also root canals and implants. Thanks.
Yeah, I know more about the bones than the implants. I'm not a dentist, but let's talk about osteoporosis. The big issue is whether or not you have it. That's the place to start. DEXA scans diagnose loss of bone mineral density, which is a normal sign of aging. I said this earlier. Most of you know you're getting older before having a test. Women lose bone mineral density faster than men because we have higher peak, because we have to deal with pregnancy and breastfeeding, which are demanding on the skeleton. So it's a useless test that doesn't diagnose your risk of fracture at all. So when women come in with a DEXA scan and they think they have osteoporosis, we just throw that out the window. Now, the bigger point is, how do you keep healthy bones? How do you keep your bones healthy? You eat an optimal diet, low acid diet, because you will suffer some abnormal loss of bone mineral density if your body has to address the acid load to keep your blood pH where it needs to be. You need sunlight, not vitamin D supplements, but sunlight. Okay, it's a whole other discussion we could go into, but vitamin D is not a vitamin, it's a hormone. And we have great studies showing that when you give people supplements versus expose them to sunlight, you get higher vitamin D levels with the supplements than you do the sunlight, but you get changes in their markers in the sunlight. You don't get it with a vitamin D. So anyway, you got to get out in the sun. You've got to have your GI tract in working order. My practice specialty is gastroenterology from the standpoint I see a lot of people with celiac disease, inflammatory bowel disease, constipation, diarrhea. All these GI issues that we have keep you from absorbing nutrients from food, including calcium. And then you have to do exercise, particularly weight-bearing exercise, because movement stimulates the building and remodeling of bones. So if you ate perfectly and sat on the couch, you're going to have crumbling bones, essentially. All right? So those are the things you have to do to build and keep strong bones. What I think a lot of people misunderstand is they think that you get to be 18, you have a full-size skeleton, and this is the skeleton you die with. It's not true. It remodels all the time. You have new bones all the time. What you need is new, hard, firm bone. And that happens from eating well, exercise, sunlight, and again, that healthy GI tract. And calcium needs have been overstated in our country. We're told that we need 1,200, 1,500 milligrams. 400 to 500 is absolutely enough, and it's easy to get from plants. I mean, an orange has 110 milligrams of calcium. You need the cofactors in order to absorb it. That's called eating it in the food. That's why you want to eat it in the food. That's the reason why calcium supplements don't lead to stronger bones. Amy Lanou, who wrote a great book called Building Bone Vitality, has a great analogy she uses for why calcium in its isolated state's not a good idea. She says the calcium is to bones what bricks are to brick walls. So if you think of a brick wall, you've got a lot of brick surface area, little tiny bit of mortar. So what if somebody said, I'm going to build a brick wall, I'm just going to stack up the bricks as high as I can, and as long as I can, I'm not bothering with the mortar. It's such a small piece, who cares? Well, the bigger the wall gets, the more unstable it gets. When you start loading the body with calcium, and it is true that the bones are mostly calcium, but there are 100,000 other nutrients in food, and the more calcium you pack in, the weaker the bones get without the cofactors. So you really want to eat the nutrients in food. There's a whole synergy in food that is different than when you pull isolated nutrients out. We probably have time for one more. And I don't know what the rest of the schedule is, but I'm around for, I have 5 more minutes? Okay, root canals, real quickly. I think that there's no question that in some instances, root canals leave behind some residual infection, but that's turned into an industry. And I don't think that all root canals are ill-advised and that they all go bad and that sort of thing. But that's probably a topic to take up with somebody who knows a lot more than I do about that topic. Okay? Yeah.
Hi, thank you. I've learned a lot already. Thank you. I really
Good.
appreciate it. I know you had said there were a lot of the preventative testing that was not needed. Which ones do you recommend as far as, and at what age? Which ones are the critical ones?
The only one I think has any value is Pap test. That's about it. Pap tests. The cervical cancer death rate has dropped in every country where that's been introduced. We do too much of it here, by the way, in countries like the Netherlands. They start at age 30, end at age 60 every 3 to 5 years, and the death rate from cervical cancer is exactly the same. It's a good test, we just do too much of it. But the rest of this is pretty useless.
So if an individual comes to you, what is your protocol exactly? How do you go through, what is your process?
Well, we get a lot of information, first of all. And I would love to tell you that we have some type of very standard thing that we do. But I think that's another area where medicine's gone off the rails. It always sounds good, some of the stuff that we want to do in medicine. There's just a lot of unintended consequences. And here's what I mean by that. We're going to standardize everything. We're going to do the same thing to everybody who comes in here, and no matter if the blood test says this, we do that, and if they have this, we do that. And it sounds good because it's supposed to lead to best practices, but what it really does is it removes judgment from the equation. And doctors have pretty good judgment if they're well trained and can exercise that judgment. So there isn't, I don't think, any one single thing that you always do it this way. Some things we always do would be to get a lot of information to establish what the person wants to accomplish, always work from objectives, and get beyond what they think the objectives are. Again, going back to what I said earlier about optimal health isn't the goal. It's what it buys you that's the goal. Pretty blood work isn't the goal. It's looking at this from what does this give you in life? Because really, changing your diet and doing something uncomfortable to get a better blood test just doesn't last long after the fear is gone. So we try and instill in people this idea that there's a great life to be lived if you can stick around long enough to do it,
So you basically, do like a consultation?
I'm strictly consultative. I'm strictly consultative. I don't have any prescribing authority, and I used to think that was a bad thing. It actually is a good thing, because basically what I can say to somebody is, look, I'm here to provide information and help you look at information so you can make decisions. I don't prescribe the drugs. I don't do the procedures. Not my body. I don't have a horse in the race. It's entirely up to you. And that takes all the pressure out of the situation, and people can make up their minds. There's no shortage of places to go get drugs. People don't need me for that. The shortage is in getting advice or getting direction in sorting out information about whether or not to take the drugs.
Yeah, that's what I'm saying,
Yeah.
not that you prescribe.
Right. It's to sort it all out.
Your role is to
Sort it out.
a
So,
journey for these people.
yeah, and we just start with, let's look at, do you have this condition that you've been diagnosed with? You've been told you have osteoporosis. Why don't we take a look at the evidence about that, and then you decide, do you really think that's what you have or not? But it's getting the person to have those realizations, because as I said earlier, doing what I say instead of what somebody else told you, you might think I have better ideas. I think I have better ideas, but that's not the point. It's doing what you say is right based on the information that you've seen. That's what the actual endpoint is from the logistical standpoint. Okay. Yes.
Okay, so I also believe that it's helpful to be informed and to pretty much manage your health along with your doctor, and if you're in a situation where you've always taken good care of yourself, but then you sustain an injury like in a car accident, and then you have real, clinical issue with like ruptured disc, how do you figure out where to go and what to do for something like that? I mean, and it's like, where do you even begin with that? Because medically they want to do things to you. Maybe you don't want to do it, but maybe there are some times where you have to do procedures for something so severe. How do you figure that out?
Well, the first thing is if I'm in a car accident and my guts are splattered all over the street, please do not give me a copy of Food Over Medicine and a baked potato, right? That's the time to just do what you're told. Let people save your life, But if it's not an emergency, the answer should always be, and our folks are trained this way. Thanks for this information. I'll be taking this under consideration. As soon as I have an opportunity to evaluate it, I'll be getting back to you and letting you know my choice, okay? And so then you start to look at ruptured disc. Is there such a thing? Does it really impact? Is this the source of my pain? They're telling me I need a procedure. What is the outcomes data on this procedure? And you start looking at it. Everything gets looked at the same way. What is the evidence to support it? And then what are the risks that I'm going to take if I do it? And then is it worth it to me? Okay, so in the situation that you proposed, car accident, you're in the ER. This is not a time to negotiate. All that you're going to pretty much let those people do what they have to do to save your life. As soon as you're past that stage, we're back to informed medical decision making. Okay, we're done? Thank you. Thanks.